Good evening and welcome. Thank you for joining us for today's presentation. My name is Michelle Zepeda, and I'm the Program Coordinator at Waterford Cancer Resource Center. Waterford Place provides programs and services free of charge for anyone impacted by a cancer diagnosis that supports whole person care. I would like to introduce our speaker for this evening, Dr. Aggarwal from Rush University Medical Center. She is the Chief Diversity and Inclusion Officer at the American Medical Women's Association and an Associate Professor in the Department of Neurological Science at Rush University. She is a cognitive neurologist, clinical trialist, and researcher in the field of population health and aging. Her clinical and research interests include evaluating the vascular contributions to cognitive impairment and dementia, and the consequences of cardiovascular disease and stroke to cognition. Welcome, Dr. Aggarwal, and I will turn it over to you now.
Well, big thank you, and thank you so much for the introduction. I'm excited to deliver this presentation via Zoom, the platform that we are, WebEx actually for tonight, but with Zoom, WebEx, all of these virtual types of platforms that we are adapting to not only stay connected, but also to continue to be educated. And tonight, discussion is really going to talk about an area that I specialize in, cognitive functioning or brain health. And I'm going to link it to overall wellness, cancer survivorship, and also cardiovascular. So it's kind of a big linkage I'm making simply because we need to talk about all of this together. And I'm going to go through some slides that you'll have after the presentation that you can refer to. So I want you to sit back and I want you to just listen to some of the things I'm going to present tonight. And that is part of a cognitive exercise. This is important. We were talking before we got queued up about multitasking. And frankly, it's not a good thing to do. And we do it all the time. And it seems, pre-COVID, we were frankly out of control with multitasking. Now we're still multitasking in different places and different areas, but if you really look at the data, the multitasking piece is not so hot to keep on pursuing. I want you to sit back and listen to what I'm saying tonight. So the first slide I have here is just the US population, and we're in 2020 right now. And if you can just see how the shape of the population has changed. So if you look at the bottom, this is, starting from birth and you're getting older. Okay, so just imagine over here, it's from like 1 year old all the way up to, let's say, 100, okay, or 110 because we're aging. But if you notice from 1950 to now, the very top part of this peak right here, they're widening, okay, and that means they're getting wider. What does that mean? That means that the oldest old is having more of a proportion in the country, okay? So you're seeing from a very like a pyramid kind of a shape or a triangle shape, it's now becoming almost like a silo. It's almost becoming just like a tube shape, which means that our base is actually not larger than the top, and that we are now seeing increased ages over time. Now, you're going to say, well, what's the impact of that outside of saying we're having an older population? What it means is that we're going to have people reaching these older ages with, some will be relatively healthy, some will not. Some will have conditions, what we call chronic conditions happening and occurring. Some will have cancer. And we are now talking in terms of what we say comorbid conditions and or chronic conditions or survivorship as it relates to cancer. So we're having more and more people coming into this age group with these conditions than maybe what we had back in the 50s, where frankly people died. They died of a heart attack. They didn't make it from a heart attack. They had cancer. They did not live as long from cancer. So we're seeing these trends. Now, there are geriatric conditions, and the term geriatrics we use for those 65 and older, okay? And it's a term we're using. We have geriatricians, doctors who take care of older adults. And that, again, 65 is the arbitrary number that we've always thought about for a geriatric, if you will, population. But there are geriatric conditions that impact life expectancy. So, what does that mean? It means that if you have two or more conditions, okay, that could be severe, chronic in nature, that is going to impact your life expectancy. And I'll talk to you about those. Disability. The term disability is being utilized a lot more now. And that term when I talk about two types of disability. You have a functional disability, the walking, and then you have the cognitive or the instrumental disability issues that are things that are impeding your ability to perform what you normally do every day, your activities of daily living. Disability is very, very important. And we often talk only about the physical. We don't really talk about the cognitive or the things that impact your ability to do these instrumental kinds of activities that lead to disability. And then we have geriatric syndrome, which means these are conditions that occur in older adults and they kind of cluster together, highly prevalent, which means they're more common. And they have a very high risk for morbidity and mortality. So morbidity means not doing well, mortality means death. And some of them are depression, dementia, delirium, which is it's a state where people are very confused. Often it can happen in hospitals. It can happen after a procedure. I'll talk about that in a moment. Falls, osteoporosis, fractures, neglect and abuse, and then, basically failure to thrive, which means as people get older, they're not healthy, they're not thriving, and that could be due to nutritional issues. But these syndromes, if any of these occur, they really impact the life expectancy. And so tonight was asked to talk about cognitive. How do you protect your cognition? How do you do things to enhance cognition after therapies, enhance cognition after cancer treatments and or diagnosis of cancer? Because it falls under this geriatric syndrome piece. And we need to get quite not only educated about this, but we also have to pay attention about what we need to do. So if we go, let's see if I can, I want to just show you just a picture. And this slide came from, it was looking at tolerance and mortality in breast cancer patients by geriatric assessment. So what it meant was, how much could you tolerate treatments, okay? If you had some of these geriatric issues that I outlined before. So if you had maybe mild depression, if you maybe have had a fracture, or you maybe have some heart condition that has been unchecked, how well are you going to be able to tolerate any kind of treatment? And you can see here that the number of these deficits, so that's a term we use a lot in medicine, the number of these geriatric conditions, the higher the number went. So from a 0 to a 4, not only was there more poor treatment tolerance, which means you weren't able to tolerate the treatment as well, but also death was higher. Okay, there was a higher chances of death. Now, it's across all of the number of these domains or these areas that were affected. So from 0, 1, 2, 3, 4. But you can see how it's stepping up and how it's getting higher and higher across everywhere and, across this spectrum. And it's really important that we pay attention to this kind of data because it tells us we need to start looking at how can we minimize some of those deficits because we want to have better treatment tolerance. We want to have less mortality. Okay. Now, there's other studies that have come out, and again, I'm showing you another picture where patient reports of treatment. difficulty. So what, when people get treatment, when you get treatment, if it's a chemotherapy or radiation, what are some of the things we're seeing with that? And many of you have heard of the term chemo brain. And many of you have heard a term, even with radiation, people will say, Doc, I don't know. I didn't get radiation to my brain in that area, but boy, I got radiation somewhere else. I'm not thinking right. Things have changed. What has changed? And so this is just showing you that difficulty in concentration has occurred in this graph, where you're just asking people, has there been changes? Okay, pre-treatment, post-treatment, 6 months after treatment. Okay, and you can see here that it's really with chemotherapy and chemo and radiation together are the ones that are really showing the peak, where there's been really a level of difficulty of concentrating was really increased. Okay, so we start pretty well the same in the pre-treatment side here. Trying to find my cursor, sorry, pre-treatment. But then over time, when people were getting treated, you can see this, it was kind of following, no, we're having issues here. After treatment stopped, 6 months post-treatment, it went back down. But again, you can see it didn't really go back to where it started from. And I want you to kind of keep that in mind. So you got better, the difficulty started to go away, but you're not coming back to the way it was. And many of you who've gone through treatments will say that, you know what, not the way it was before I started. Things have changed. Okay. Now, the other thing we looked at here is memory over time. So concentration is very different than memory. And, I'm a neurologist, I'm a cognitive neurologist, and I pay attention to this because concentration is focusing. And I'm going back to our multitasking thing that we just were chatting about before I even started tonight's discussion. When you multitask, you aren't really concentrating. Think you are. But what you're doing is you're short-circuiting that concentration loop. So when I say concentration, I mean deep concentration. Many of us right now, frankly, don't have that deep concentration we used to have, just by the way things have occurred with technology. Even what we watch television. When we're watching television, the TV shows were not as long, 20 minutes. That's what we're looking. If you're looking at your phone, it's constant flipping, flipping, flipping. So deep concentration for an extended period of time has changed. Memory, however, is more of what can you recall when it comes with data, facts, places that you've been. Memory is a different place in the brain than concentration. Concentration is in the frontal areas of the brain. We think it's localized there in the brain. And there are connections that go deep in the brain to go to the frontal area. So the concentration that we focus on is really frontal. Memory is an area called the hippocampus, which is over the ears. And it's a brain area which is roughly over the ears. And that is really important for the initial parts of memory, short-term memory coming in and getting processed to long-term memory. When you look at treatments, pre-treatment and again post-treatment, if you notice the chemotherapy here and the radiation, just as we saw with the tension and concentration, you see it's mirroring the same thing, right? But you're also seeing here that radiation is affecting memory and it's not going back down. It looks like radiation here is still going to be is still higher by itself. Why is this important and why is this graph important? Just to get a concept that after your treatment, there are going to be differences and there's going to be changes. And frankly, we are expecting those changes. What we're interested in and what you're interested in is how do we get this to go down quick? How do we get my difficulty level, which is really hard and it's getting hard for me to concentrate? How do I make it get back to somewhat back to normal? Same thing here. How do I take it from memory, from having difficulty with my memory? By the way, it would be short-term memory as opposed to long. How do I make it come back down to at least as close to my pre-treatment levels? Okay. And that's where a lot of, excuse me, that's where a lot of the work is looking at right now. Now, the term I use a lot is mechanism. So I can tell you about this, and I already talked a little bit about the brain, where the frontal lobe is really important for that attention loop to keep things going and to keep you on track to focus. Okay. And the hippocampus is important for memory so that when you're listening to me tonight, for example, you're doing both things. You're focusing and you're focusing on the slide for concentration, and you're using your ears to listen to me and also consolidate some of those memories. So it's coming in a short-term memory. The more I talk about it, the more you hear it. We are hoping it will encode into long-term memory. Okay. But the question is, what's the mechanism? And why are we seeing these changes in chemotherapy and radiation? And if we understand why these changes are occurring, okay, and what could be the pathway of why they're occurring, then we can do something to treat it. So when you think about preserving your brain health, it's really important first to understand the why. Like, why is this even happening? And then when you understand the why, then you can say, okay, if this is what we know is happening, then maybe we need to focus on different pathways of trying to make it less. Okay. So the first thing, which is obvious and everyone here knows, cancer treatment. Okay. The treatment itself is not good. The treatment itself is not good for the body. And, for the, say, healthy tissue in the body, we're trying to minimize that risk of hurting healthy tissue. But for a brain perspective, okay, the chemotherapy and the radiation are just not good for the brain cells. So the brain cells are very, very sensitive, and the brain cells need a lot to survive. So your brain needs a lot of oxygen, and it needs a lot of blood carrying that oxygen to your brain. And when your brain doesn't get enough oxygen, what happens to you? You feel faint, you feel dizzy, and you will pass out. And when you fall down to pass out, or you will go flat, lay down, that is the body's protective mechanism to try to get blood back up to your brain. So when people say, oh, Dr. Aggarwal, I feel really, really faint, and it can be a younger person, an athlete, I feel faint. What do we say? Put your head down and try to put your head down, and we're trying to get blood into your head. Why do we want blood into your head? We want blood into your head because it's carrying oxygen. Oxygen going to the brain and to the brain cells nourishes those cells and keeps them working and keeps them functioning. Okay. But in addition to the cancer treatments that are being, let's say, provided or the radiation therapy, we also know that they can cause trouble with clotting. Okay. Small blood vessels can start to clot from the treatment. Now, again, how does that relate to cognition? How does that relate to brain health? Well, you just think of small blood vessels clotting, you start to think of stroke. And you start to think of small strokes, not big ones. It doesn't have to be big ones. It can be these small little strokes. And now what we're seeing quite a bit is this thing called microhemorrhages. Hemorrhages in the brain, little tiny ones. They're like little specks, okay? But they're hemorrhages, and they show up a certain way in the brain as dots. And there's also issues where that when the blood is clotting in the small blood vessels, just think that blood flow isn't flowing as well as it used to. And again, we don't have enough oxygen going to certain parts of the brain, and then you start to feel faint, and or you may start to feel what I say dim. People say, I'm just not, gosh, I'm not thinking well. I don't know what it is. It's like I'm in this fog. And the question is, what is the blood flow going to your brain? How can we increase that flow? And I'll talk a little bit about exercise later on. Okay. The other thing that's there with treatment, hormones. So what are the hormones in your body that you normally make? Endogenous, which means stuff that's already in your body. Your endogenous hormones that are there. We have lots of hormones, and it's not always sex hormones, meaning it's not always the estrogens and the testosterones. But I have to say, the estrogen and testosterone is really, really important. And it's really important for cognitive health. We don't really think about that, right? We think estrogen is really important for the gynecological, the OB-GYN, reproductive areas. And same thing with testosterone. We think it has a lot to do, obviously, with masculinity, but and muscle mass. But we're also thinking of it more as, again, a reproductive type of a hormone. But both of these hormones have effect on the brain, and they also affect how people feel, i.e., able to concentrate better, or their memory is better. So that's one thing that we see. So again, treatments affect these hormone levels. The tricky part here, though, is with the hormones, is if you say you're low on a hormone, the question is how much to give. Because if you give it now, it's not naturally being produced, or it's not naturally the levels it was, and now you give it to someone, that has side effect profiles that are very, very important to understand. And where these side effect profiles, a lot of them have a problem, is with the blood. They can cause clotting of the blood and you can get stroke. Okay, so that's an important thing to remember. The other thing here that can cause changes in thinking has to do with depression, fatigue, and anxiety, which is very common in treatments and post-treatment, during treatment, post-treatment, even the diagnosis prior to treatment. And you're going to say, well, how do you get rid of all of these? Well, again, one of the things to remember is the depression, fatigue, and anxiety, it's all chemicals, it's all neurotransmitters, it's all things in the body that are out of balance. And so the question here is, well, what's out of balance for depression? Is it a certain transmitter called serotonin that's really important for well-being and how you feel? And if that's the case, then an antidepressant is prescribed. Anxiety is another very investigated type of feeling. When people are anxious and nervous and they get heart palpitations and start sweating, what happens is your nervous system is in overdrive and your nervous system can't calm down. The question is, how do you calm that nervous system down? Not necessarily only with medications, but the nervous system, how that's operating, what can you do to naturally calm it down? And in many cases, it's going to be physical exercise can calm the anxiety down. It's a pathway to calm the nervous system down. Cytokines are something that have always been around. Fancy words for inflammatory response, okay? Cytokines are very, very common. The thing with cytokines is that they tend to get out of control when you're dealing with any kind of treatment, and any kind of treatment that is messing up the body's, I'm going to say, the body's environment where these cytokines go. So you may hear interleukins and these kinds of words. Your doctors may be talking to you about antibodies, etc. Lately, because of COVID, we are hearing a lot more about these cytokines, because what's happening in COVID is that this COVID infection, and when it started, we started to see what was in the news, cytokine storm. And just as the word storm, you think of what a storm is, that's what was going on in the body with these cytokines. Way too many of them were being super activated and higher levels than normal, causing basically an attack on the body. And you started to get this massive inflammatory response that just didn't stop. And what did that do? That led to changes in the heart system, that led to changes in the hormones, that led to clotting again. And that's why some of the stroke numbers started to go up quite a bit in younger people who had this really strong cytokine response with COVID infection. And then the last thing when it comes to cognitive functioning is genetic predisposition. And, I put this in here, meaning there are some conditions that are genetic where you can say, well, I'm not thinking well, and I'm losing my memory. My mother had this thing called dementia, and it runs in our family, or there's another neurologic disease, and there's a genetic predisposition. I'm going to say yes and no to that, because the genetic predisposition is not as big a factor as all these other factors, and we'll talk a little bit about genetics. So I'm going to switch over now to think about, we talked about this concentration issue, and I put down concentration and attention go together, right? And then you talked about memory. But there are a lot of different other kinds of cognitive functions or skills and that are tested for, okay? Now this testing can really be anywhere. Okay, this testing can be done in the primary care office, where it can be a screener, is what we're advocating, a quick screen, and I'll talk about that in a moment. It can go to full-blown neuropsychological testing getting done, and a lot of times the docs will do that too because it's more detailed, because the neuropsychological testing can start looking at all of these different things, right? We talked about emotions, right? The anxiety, depression. Motor functioning is really your ability, how fast you move. And the way we assess that on a cognitive test is we ask you to do finger tapping, or actually taking a pen and writing a sentence. Drawing, that's motor. And we want to see how well you move your hands with that type of thing. We even ask people on cognitive testing to get up, stand, and walk, and see how fast you can walk at a certain speed or a certain distance. And it's called the timed up and go task. Visual spatial skills can be assessed. And we see a lot of times when people are going through treatment, and after treatment, they'll say, gosh, you know what? For the life of me, I just am not good. I can't measure things the way I used to. I can't predict how big something may be. It's a visual spatial task. It's a spatial thing. People notice it sometimes driving the car. You know what? I can't get in the garage. I just cannot get in straight, or I can't get in the garage. That is a part of the brain in the back part. It's called the parietal area that tells you where you are in space. And a lot of times that can be affected with treatment. So it's visual spatial. The big things, though, with the attention and concentration really fall also under this area called executive functioning. This is a big deal. This is the part of the brain, but especially a part of cognition where you've got to get stuff done. I want you to think of executive functioning just like the word executive. A CEO, you're getting stuff done, and that means putting a task and starting a task, finishing a task. Doesn't mean you do it fast. It just means that you finish it and you complete it. You're executing. And that ties in a lot with this processing speed. How much information is coming in and how fast can you process? We see a lot of changes going on, again, in treatments with people during treatment, of course, but after treatment, remember that graph, things start to get back to somewhat normal, but not at baseline. The lingering effect people will say is, Doc, it just takes me longer to get things done. And then my question always is, but when you get it done, do you get it done? Meaning, are you finishing the task? And if the answer is yes, I'm finishing the task, then I'm going to say stick with it. And the brain has to rewire itself to learn, again, how to speed it up. The circuit is there. It's just we have to speed up the circuit, ratchet it up a bit, okay? We talked about attention and concentration, what that's about. Focusing on what's said, focusing and concentrating on what you're doing. And that's a tough one because in our society in general, we are not being told to concentrate. If anything, we are constantly being told to be distracted. So the pinging of the phone, the pinging of my emails, everything breaks up that ability to concentrate. Okay. And then it takes more time to get back on track. And then memory. Now, memory is an interesting thing. There's short-term memory and long-term memory. But there's also verbal memory and visual memory. And many of you already know, probably intuitively, what type of memory you operate on. It's very interesting. You see it a lot in kids. Some kids are visual learners. They see it, they get it, it sticks in the mind, that's it. Other kids are not visual learners. They are verbal learners, okay? They need to hear it. And they need to hear if they don't. These are the kids, and even older adults too. They aren't the reading people. They're the ones who are saying, I listen to audiobooks, but I remember what's in the audiobook. Other people are like, oh my gosh, are you kidding? I need to look at something. I want you all on this call, I want you to figure out where is your strength. And the reason I'm saying this is that if you understand where your strength is with memory, you're able then to exercise that strength even more. I'm not interested in where you're weak. I'm interested in where your strength is, because we're going to exercise the strength by doing more memory tasks that kind of play to that strength. And that's going to help All of these kinds of things that I'm outlining here can all be done in what I call brain hygiene. So the attention concentration is reciting phone numbers, which we probably don't even recite anymore. We used to remember phone numbers. We don't do that anymore. We look on our phone. But we used to remember phone numbers for everybody. Start remembering numbers, say them forward, say them backwards. That is a great attention concentration task. Executive functioning is how many steps does it take to do something and finish it, execute. The processing speed comes as a byproduct of that. The more you do something, the faster it can be done. The visual spatial skills, jigsaw puzzles, puzzles and things where it makes you want to place different objects in different places. Now, if you're handy with your hands, which many people are, I have patients who make quilts. That's a visual spatial task. It's a motor function for making quilts, but it's visual spatial. You need to know where to place all of the patterns and how you do patterns. That's spatially knowing where it goes. The motor function, again, fine motor is important in walking, and then the emotions. So one of the things that I get asked by docs is, all right, I have a patient's going through some treatment. What should we be doing right now to assess cognition? And one of the things that part of my work that I'm going to be really focusing on and making aware that we need to get a baseline screen prior to starting any therapy. And it's not consistent. I've heard of patients saying, no, doc, you know what, my doctor actually, he did a memory screening test called the MoCA, and it's the Montreal Cognitive Assessment Test. We're doing that much more than the mini mental test. We used to do the mini mental years and years and years. It became copyrighted. So we're not really doing that test. We're doing a MoCA test, which is similar. It asks questions about remember these 5 words, name letters, name as many words as you can that start with a certain letter, do some digits forwards, backwards. It's a nice screener, and we've done in about 10 minutes. But it gives a number to tell us how people are doing. And screen before you start therapy. Okay? And then during therapy, if something changes, at least you have a baseline screen of what the score was and we can monitor changes. It's not uncommon while you're in therapy, you can get that MoCA test done again. Many patients have subjective memory complaints, and it's very common. It's actually very common in people who are not even having any kind of therapy done, that my memory isn't the way it used to be, not the way it was 10 years ago. These are what we call subjective memory complaints because we don't have any objective, we don't have any testing to say that there's any issues. Even when the testing comes back normal, okay, in patients that I see that don't have, let's say, treatment for any kind of cancer, et cetera, even then, we do have these subjective memory complaints. We're beginning to take them seriously because it's telling us that there's been some kind of a change, okay? But to go ahead and have a screener would be really helpful to see where people are, how they're doing. Now, the mini mental test, traditionally, and some of you may already have had this done. What's the date? What's the year? Who's the president? What state are we in? What zip code? All these kinds of things. It's not really sensitive to memory issues. And you can get a score out of 30. You can get a 26 or 27 out of 30 and still have some real issues. And you're going to say, well, that's a pretty good score. 27 is not bad. But it still can miss things. So that's why we're going into this Montreal Cognitive Assessment Test called the MoCA. And the other thing that's important about the MoCA that I like about it, it's translated in different languages. Okay? So if you're coming in to a physician office and English is not your first language, it would really make sense that you would probably want to be tested for memory and thinking in the language that is your first language, because traditionally the first language is what you've learned the best. Okay? And then the MoCA has many, many, many languages where it's been translated and validated. Okay? So you can have an interpreter, or if you don't speak the language, actually read out the question and not have the interpreter figure out how to say the question from English to that language. This is really important. And we've been pretty slow to kind of realize that we need to be doing this. And so I'm happy to say that MOCA does this. And then we have to rule out all those other causes I was talking to you about. Now, I want to switch gears a little bit because as I'm talking about cognition for a moment, you're thinking, well, okay, so we talk about thinking. What's normal thinking and what's not normal thinking or cognition? So you have normal, let's say, aging and thinking, and then what is going into that dementia or that Alzheimer's dementia? And there are really two ends of a spectrum, right? There are two ends. One is normal and one is not. Aging changes, things that occur with aging over time are you can make a bad decision once in a while. Oh, well, what was I thinking? I didn't think it through. Maybe missing a monthly payment on a bill. Occasionally, you may overpay or pay twice. Um, Age related, you can forget what day it is. And right now with COVID, boy, are we having this going on. Not only are we forgetting days, we're forgetting times. Our whole system right now is totally, totally messed up. And people are telling and just saying it like that, it's messed up. I'm not going to the bed the way I used to. I just don't have that regimen. I don't have that structure the way I used to. So, right now, forgetting a day, what it is, remembering it later is a normal kind of an occurrence. Forgetting which word to use sometimes, losing things from time to time. These things all happen as you get older. The issue here is it shouldn't be impairing your ability to do your activities of daily living. Once it starts to cross over into, I'm having real issues now. So now I'm really misplacing everything and I even can't find it, even when I retrace my steps. I now am not just having the occasional word issue. I can't carry on the conversation. I forget what I'm saying completely in the conversation and it's not even coming back. Losing track of the date completely or the season, thinking that it is not just, 2020, but it's, 2007. That is a big issue with people who are having dementias, especially Alzheimer's. The money is not being managed properly and poor judgment consistently. So the issue here is consistent, okay? Now, this is occurring in people and when we say there's a dementia, we're saying that there's nothing that could be causing this behavior. And that, under that category, means if you're undergoing treatment and if you're undergoing cancer treatment, chemo, radiation, had a surgery, getting another surgery, and these issues are occurring around that time, it's really not correct to say that we're dealing with a dementia. We're dealing with cognitive changes, but we're not necessarily dealing with a dementia because there's other things occurring that could cause this to happen. We just went over that the chemotherapy and radiation therapy does cause issues. Now, the thing with Alzheimer's, though, and the reason I'm bringing this up here is that right now we believe there's at least 6 million people who have Alzheimer's dementia. Two-thirds of the Alzheimer's cases are women. It is a woman's disease, and it's right up there with heart disease for women. It's right up there with breast cancer. It's right up there as a woman's disease, okay? And this is something relatively new and we're trying to understand why. We do not think it's because women only live longer than men. We think there's some real biological issues that are different with women and men, and that somehow the brain is responding differently in women and compared to men. Hispanics are about 1.5 times as likely to have Alzheimer's dementia compared to whites, and African Americans are 2 to 3 times more likely. Asians, we're not sure yet what the Asian numbers are going to look like, but we think the Asians are going to be like the Hispanic numbers or 1.5 times. 1 in 3 seniors will die from some form of a dementia. And again, a senior here would be 65 and older. It's the 6th leading cause of death in the US, more than breast and prostate cancer combined. Okay. I think this is an important piece, and I'm bringing this up here to this group because when we talk about cancers, and especially breast cancer has, the education about breast cancer, the visibility about breast cancer is very, very high. And when we look at the numbers of people dying, from diseases, Alzheimer's is the sixth leading cause of death. So it's really, and it's climbing more as being one of the, moving up into the leading cause of death ranking, costing the country a lot of money, and more than 16 million people are really providing care for someone who has Alzheimer's. All right. Now, on that backdrop of what Alzheimer's is, and you can see here the numbers of who is developing Alzheimer's, the question becomes, well, what are the risk factors for Alzheimer's and what are protective? And this is a slide that really I get asked all the time to show this slide. What are the risk factors? So age is the number one risk factor. By the time you're 65 and older, the chances of you getting a dementia go up every 10 years, okay? So that by the time you're 85, there's a 1 in 2 chance that there's already some dementia occurring, most likely Alzheimer's. Women, we talked about that. There's a certain gene, the ApoE4 gene, that can put you at risk for developing Alzheimer's, but not necessarily you're going to get it. And we're trying to understand race differences with this gene. Is it operating the same in white and non-white populations? It has a stronger effect in women, this ApoE, than in men. Diabetes is a risk factor for Alzheimer's. Cerebrovascular disease, stroke, cardiovascular disease, heart disease are risk factors for Alzheimer's disease. It never really was thought about that. Depression, distress, these things, these mood issues are also some risk factors for Alzheimer's. And then Parkinson's signs. Now, what's protective is cognitive activities and years of education, physical activity, and social activities. How much are you networked? Now, why am I showing you this slide? I'm showing this slide because we're really focusing on a lot of these risk factors to prevent Alzheimer's disease. But what we're also understanding is that many people who are undergoing therapies and undergoing cancer therapies and are younger or are coming into that age of 65 where we know this is happening, what can we do then to take what we're learning and bring it to our populations who are in the 55, 60, 65-year age group to say, how do we protect you as you get older when you are living with as a cancer survivor? We're also realizing that memory function and metabolism go together. And I want you to take a look at this. Exercise, physical activity, restricting your calories and nutrition are really, really, really important. And if you don't go ahead and focus on that, and you go over to the teeter-totter here where you start to get into the sedentary lifestyle, metabolic syndrome, diabetes, etc., and stress, you can tip basically the scale to lead more into a dementia. So our focus is really now honestly going into this lifestyle management and saying it's not just that you want to live a healthier life, but it's good for your brain and that there is science behind that. Okay? We all know this. It is the new smoking, being sedentary. And unfortunately in COVID, this has really challenged us and how active we used to be, especially when it first came out, when the pandemic first started. This was a really hard thing for many, many people. And it still is for many people. How do I keep my activity level up when I'm also trying to keep myself safe? But we do understand that sedentary is really bad for you. Why do we exercise for the brain? And this can be, by the way, any type of exercise, cardiovascular, walking, yoga, dancing, you name it, I'm game. It's all good. You need to keep moving, but look at all the things that just physical activity does. And it is affecting your brain. You're thinking, well, it's really good for my heart. It's good for my muscles. It's good for my bones. And I'm going to tell you, no, physical activity is good for your brain. And physical activity through treatments, post-treatment is even better as best you can. People are tired, there is fatigue, and there is real fatigue. But to just keep moving can reduce all of these types of risk factors, not only for the heart and for your cardiovascular state, but what about the brain? The brain functioning can be enhanced. Now, nutrition is a huge issue right now. The Mediterranean diet is the diet we talk about quite a bit. It's been a very important diet. It has been studied for many, many, many years as a heart-healthy diet. And you can see this is the consumption of what we suggest. I realize and I understand people coming off of therapy say, Dr. A, I just don't taste anything. The food is bland. I just can't taste anything. And I have a metal taste in my mouth, and that can be coming from some of the medications and treatments that you were on. Trying to get this, however, in the diet, unless there is a reason why you cannot try to consume these types of foods, whether it be the fruits, the berries, etc. Honestly, the data is showing that this is a very important diet, and specifically the berries, okay, which are going to be the blueberries, and the nuts, which are going to be the walnuts, are very, very important in addition to the olive oil. We are doing a study at Rush called the Mind Diet Study. We're almost finished with the study with regards to intervention, where we've been giving people the actual ingredients that combine this diet in addition to green leafy vegetables and following them for 3 years to see how is their memory functioning over time. If they were given this diet, they were given the olive oil, they were given the berries, they were given the nuts. We believe in this diet, and there is no reason to suggest that this diet is not going to be helpful as we look into persons with cancer. The last thing I want to bring up here is that there is a study that we've been started, then we had to halt because of COVID, because we could not go out in the field and see our people and bring our people in, but it's called Pointer. And the Pointer study is being done at Rush. It's also being done at Advocate Park Ridge, here in Chicago area. But it is a study where we're really looking at healthy lifestyles and how can we protect the brain. And it's looking at 2 lifestyle interventions. Exercise, diet, cognitive and social activities is really what we're going to be offering people. And we're going to then have coaches, and they're going to be exercising, and we're going to follow through to see if this type of a lifestyle is going to change any, basically lessen any changes in cognition over time. So it's an exciting study because it's a lifestyle study. And one of the things we're trying to understand in this study is if we implement this lifestyle change and we have measurable change in thinking, but also the brain changes, we're going to do an MRI on people. We're going to do PET imaging, which is a special scan on people to look at the brain. If these changes look good, that they are less because of this lifestyle intervention, then we actually have a prescription to people to say this is what we need to do, okay? And it could be community-based. We're doing this all in the community at the local YMCAs. Now, because of COVID, we've had to think about how to adapt this therapy. Like right here, I'm coming to you through WebEx. We're looking at how to adapt some of this intervention until we can start to go back out, but people are coming in for evaluations. There's 2 groups. There's a self-guided group and there's a structured group that will be randomized. And basically the self-guided is going to design their own lifestyle intervention for them. The structured group is going to be provided with the lifestyle intervention, and we're going to measure this in people. Okay? Very exciting study because it's really bringing everything together. And I think, for you who are listening tonight, you may say, well, I don't know about myself, but I may know someone else who's interested in the study. All you have to do is call us at Rush and see if you or someone else would qualify. Typically, when it comes to patients who've had cancer, and when it comes to trials, we always ask where are you in that journey with the cancer, and how many years out, or when was your last treatment. Sometimes people can come in, sometimes people cannot be screened, but nevertheless, it's an important study because we're really looking to see how this is going to affect cognition and thinking. And the big thing right now, I'm happy to say, is that we're taking that kind of a diet intervention, multimodal, and we're going to start looking into that with stroke patients. So we're going to start giving a specific diet to people who've had a stroke who go home, and we're going to follow and see if that diet is going to change any changes in thinking that happen after stroke. And even a small stroke can cause changes in thinking. So we're really embarking on that now at Rush. I'm happy to say that that study will be coming soon. But in the meantime, the question is, how do you preserve your cognitive functioning? I've hit the diet piece pretty hard here, which is important. You got to get moving and you got to keep moving. Your brain needs it. Your body needs it, but your brain cells need it. The sleep issue comes when really the diet and the moving get really in a rhythm. But sleep is one of the things that is constantly disrupted for so many people. It's been totally disrupted from COVID and sleep-wake cycles. Yet it's such an important piece. And how do you sleep? People say, I'm just not sleeping. And what I say to everyone is, you have to figure out, how do you get good sleep hygiene going? Either you cut off the computer, you cut off your phone, you listen to maybe music, or you do a bath before you go to bed, something as a regimen that you're saying, okay, I'm going to bed now, and I'm going to sleep now. And, not to make it an anxiety issue. So I use the Calm app quite a bit for my patients. And I ask them to get on the Calm app, CALM. And on that app, they have bedtime stories and they have music for sleep. And I ask my patients to try to use that to help them get in a regimen. The last thing is the reducing stress can come. It's amazing how stress reduction comes with the moving and the diet. It's an incredible thing how stress reduction happens between those two things. But honestly, improving social engagements with people you like. I say this all the time, and people always smile when I say with people you like. But there's a lot of data that is out there that people who you are lifted up by and you enjoy being with is really good for your health. Your endorphins go higher, your positive hormones go higher. Everything gets higher in your body that is supposed to be higher, meaning to make you feel good, especially that feeling, that genuine feeling of well-being. And you need to really take a look at the social engagements and really pay attention to them. Now, COVID has, again, really hit us hard here. And there's a lot of people saying to me, Dr. A, this COVID thing, I don't know, I'm getting forgetful. I just can't remember everything. I'm just not around people. The interactions that I wanted, I really need that. And the point is, yes, we need that. We're social beings. So it's a very real thing, but it's also a very real thing about what you're listening to, who you're around, and what are you putting in. It's affecting your body, but it's affecting your cognition. So I really need you to really pay attention to the social engagements and anything that you listen to. Is this positive or is it negative? And if it's negative, you have to eliminate it because it's totally going to undo all the other things that you're doing to keep your brain healthy. So I think with that, I think I'm going to stop and see if go back into the mode and see if there are any questions for me. I went through quite a bit tonight, I want to leave a few minutes for questions. So I'm going to hand it back over to the group and see what we have.
The next question we have is, how does anesthesia from surgery affect cognition?
Yeah, it's a really good question. So anesthesia from surgery is really being relooked at again. I remember last year we had a similar question because so many people are going through procedures. With surgery, so you're in surgery, so not only are you getting anesthesia, but then we're also looking at blood pressure changes, right? We try to keep the blood pressure at the same level in surgery. We try not to have spikes in the blood pressure, but we also want to make sure the pressure is enough to not only keep the organs functioning, et cetera, but also brain. Anesthesia in itself, if you will, the toxic part of anesthesia or how much anesthesia or how long people are under anesthesia, we're still trying to understand how it's playing into your overall general medical health. And remember that one slide I was mentioning about comorbid medical conditions. And if you're older, let's say, the more comorbid medical conditions, it's not a good indicator for treatment or for how you respond to therapies. Well, anesthesia on top of the comorbid medical conditions kind of muddies the water. So the issue here is how much of it is really due to the anesthesia and how much of it is due to the body not being able to, frankly, clear some of that anesthesia out. Okay. And it's coming through the heart and the vascular system. So the heart pumping, clearing out all of, basically that anesthesia from the system and getting more oxygen to the brain. That is the biggest question. We do know, though, that we're advocating that if we can get some baseline testing done before a surgery and before anesthesia, let's say, is given for a surgery, and then we can measure this afterwards, that would be really ideal. Because then it not only tells you and the surgeon and or the healthcare team where you're at, but also afterwards, if there are changes or no changes. You may have subjective changes, but at least it puts everyone at a little bit, not at rest, but a little bit at ease about we're monitoring this. I would say, though, post anesthesia and post surgeries, you do want, again, I'm going back to the lifestyle, you do want to keep the movement going. You want the blood flow. You want that nutrition to kind of go in there. And if there is some deficits there with the tension and focusing, you want to really enhance that. And that's how you can do it through the nutrition and or the exercising, ideally both.
Our next question is, what are the concentration and memory results past 6 months?
Yeah, so those graphs were showing where we were right post 6 months. Afterwards, that's a great question. Some of the graphs and some of the data shows that they start to approach what I would say the pre-treatment levels where they were, but a lot of times they level off. And what that means is that they start to go down, meaning they start to go back to normal where you were before. They never really hit the baseline, but they level off and they don't keep on getting worse or they don't really improve. So there's a leveling off. Okay. Everybody's different though. Okay. And this is important. Everybody is different. Some people, they'll notice that it's leveled off, they're fine, there's been no gains and there's been no more losses, and their body and their general overall medical condition has stabilized. Other people, and you know this, and everyone who's here on the call, there's another medical condition that comes up. There's another issue that comes up. And, there's like another hit, if you will. And that's when we start to see then changes again in the cognition. Sometimes it can be the first sign of a change. The thinking is changing now. They leveled off and now something happened and now the cognition is changing. And that could be an alert that there's something else going on again and that we need to investigate. But again, everyone's different. Traditionally, if you're younger, you may have more what we say cognitive reserve. And that's a term we use where it's kind of like you've got more reserve in your brain that you can kind of, fight against things that may be, coming in through treatments versus an older brain that may have less cognitive reserve. But we're relooking at all of these things because there's so many people who are now living to very older ages and doing really well. And frankly, doing better than some of the younger folks that may not, who are not doing well. And we're trying to understand that. So cognitive reserve and resilience are two big issues that we're really trying to focus on, and understanding what makes someone have more reserve than someone else.
Next question, should we be doing specific cognitive or brain exercises?
Yes. And I'm going to say yes. The question then is, well, what are they? Well, what are these brain exercises? So the ones that we studied at Rush quite extensively, and we call them cognitive activities, okay? And a lot of them had to do with puzzles. So crossword puzzles are a big deal. You're going to say, no, why crossword puzzles? Well, crossword puzzles, if you think about it, it's a visual spatial, right? You're trying to figure out where the words are going to go and fit in the boxes, and then you're trying to figure out horizontal and vertical. And that's a visual spatial task. You're manipulating how that word is going to fit and where is it going to fit within the puzzle. Okay, so that is a cognitive activity. It's utilizing different parts of your brain to figure that out. Jigsaw puzzles are another thing that are really important, and they're good to do if we even do them. You can go on the computer now and go ahead and find different kinds of cognitive activities where you're putting pieces in on the computer. It doesn't have to be on the typical jigsaw puzzle tabletop. The other activities that are doing the numbers forwards and backwards, okay? Remembering the short list. These are all cognitive activities. Music, if you are an instrument, you play an instrument, keep playing it. That is a cognitive activity. It is, again, not only sound, but what is the next note? Reading music. There are other activities that when you think about for brain enhancing activities, this is, pre-COVID, we would always ask, how much are you going outside? Museums, plays, concerts, those kinds of cultural activities, painting, dancing. Dancing, by the way, I want to bring up for here for a moment. Dancing, and this is something you can do at home. You don't really need a partner, but dancing is a terrific cognitive activity. Because if you dance, you have to remember the steps and the visual spatial, the movement, all of that is a real true, it's not just only a great workout, but it's a cognitive workout. Okay. And I think that's really important to focus on too. The NIH on its site, the NIH, which is the National Institute of Health, if you type in NIH cognitive activities, you will see a list explode of all the different activities that we're researching and we're understanding and how important they are. And they will go through those activities for you to do. Sudoku is a great thing you can do. There's just so many things that you can do, and trying to do something different in the mix is also important. So you may say, Dr. A, I love crosswords. Great. I'm going to say, all right, step it up a notch and maybe get a harder crossword, or maybe do one where the numbers aren't there and you're making your own crossword. You're turning the activity around a little bit to do something different, right? And even driving, when you were driving around and you went a certain way to the grocery store, a certain way to work, I would always say, you know what, turn it around a bit, go different. That is a cognitive activity. It's not like you're getting lost. It's you're finding a different way to get someplace, and that is really utilizing your brain. No, instead of going this way, I would have to make a left turn, then I do a right turn. That is all part of cognitive activity of utilizing the brain.
And we had just because it's related, someone says that they do knitting. Is that a good cognitive
Yeah,
activity?
it's totally terrific. Yeah, knit, purl, drop. Yeah, totally. It's a great, knitting is a great exercise to do. It's also a concentration exercise, especially when you're following patterns. And as you can tell me by saying knit, purl, I learned a lot from my mother, who used to knit quite a bit, and I would watch her. She really focused on that pattern, and she made Afghans, and I remember watching her and how she did this, and sweaters, and she would, don't talk to me while I'm knitting this stretch of what I'm knitting because I have to focus. Again, great exercise to do. The quilting I told you about, the needle pointing, all of those things require attention, fine motor movement, especially with the hands, but it's also part of how does this all fit in? So yes, total thumbs up on knitting.
So we have two more questions here.
Mm-hmm.
So, are there things you can do immediately to improve energy and concentration? For example, eat walnuts, use tapping and grounding, essential oils.
Mm-hmm. Yeah, so I think immediately, I think you got the diet piece down right there. And, one of the things people always say to me, well, should I be focusing on the diet or should I be focusing on my activity? To increase my activity and to increase my energy, even though I'm tired and I'm fatigued. And I'm going to tell you that it's an interesting thing. If you focus your attention on your activity first, movement, and again, movement, we are not meant to be sitting all the time. We are meant to move. If you look at my hand is made up of multiple joints. My fingers are meant to move. Moving your thumb, moving your fingers. These are, you're going to say this is, well, that's just so basic. And my answer to you is yes, it's basic, but we are really meant to move. So first start the movement, and you could do the chair exercises. You could just do the shoulder rolls. Again, if you want to have a good app, I love that Calm app, CALM. That app has some chair exercises for all different levels, for all different times. I only have 5 minutes. That's all I can do. Great. Do it. I want you to start moving first. The more movement you start, what you're going to notice then is you are then going to want to eat better, better than you probably are eating now. And you're going to want to, you may start craving the healthier items. And that's when you want to bring in the nuts and the berries and make sure the fresh fruits and vegetables are at every single meal. If you can eat them, I want you to eat them in smaller portions, but I want you to eat that. Somehow the physical activity feeds the eating behavior. Okay? And you're more over time, you're going to notice you're not going to really want to go for the caffeinated or the caffeine items because that's taking away from everything. Now, the essential oils and the aromatherapy, that type of activity is wonderful to do, and it may be helpful for sleep. So if you have certain scents that can help you sleep, a really nice scent, I'm going to say have it in the room. So now you're able to bring in, overlay the sleep mode in here so that you try to get good sleep. Okay. Very, very important to do this. And frankly, very important that you turn the iPad off and you turn the phone off in the bedroom. You don't want that blue light. You don't want that light. It totally messes up the circadian rhythms of what you should be sleeping. And we need this now even more because of the COVID issue where so many people are still in the homes restricting their movements. They're not going out the way they used to. So diet, first of all, the movement, then you go to the diet, then you can do the essential oils, and then you can start to do some of the activities, the cognitive activities are also helpful. All of these things together help to calm you down, where you feel a sense of peace and you also have a sense of wellness. Now, meditation is one thing that, people will say, I have to do it in the morning. I can only do it in the morning. Or some people say I do it at night. Again, there are multiple apps that can help you if you need to get started on meditation. But meditation really is that sense of sitting with yourself. That's all it is. Quiet time for yourself before anything else gets started during the day. And that is really, really important for everybody's healing, but for everyone on this call, it is hugely important because it basically gets you set to either start the day with a calm mind or you're ending the day in a state of calm, which is all very, very good for your brain.
And our last question is sugar bad for the brain?
Yeah, good question. Yeah, sugar is not great for the brain. I have to say that. Look, the brain needs fat. The brain needs fat for certain cells. Okay, we need that, and we need sugar as the energy source. The trouble is with sugar when it is too much, and we have too much of it, like the diabetes link I was mentioning. The brain is losing its efficiency in utilizing that sugar. So it's like it's not utilizing it as best as it should. And what we're finding then is we now get into a state where the cells aren't responding the way they should. Okay. And so that whole thing about caloric restriction and what are we eating and monitoring what you eat and how you eat is really important. Now, we all like sugar, we all like refined sugar, we like cakes, we like pies, we like all that. But it depends on if can you get that sugar within, the vegetables and some of the fruits to bring it in a way, a natural state is really what we're going for. But we are seeing with diabetes, even, type 2 diabetes, even controlled, over time in our studies, we're seeing that people, not only is the brain shrinking in diabetics compared to non-diabetics, but the diabetes in itself is not good for cognitive functioning over time, okay? And this effect is more pronounced in women compared to men. So when you take a look at your diet, when you take a look at what you're eating, you want to say, okay, I need to get this amount in, and this is where a dietitian is very, very helpful. I didn't bring that up actually in my presentation, and I think I should mention this. Trying to get a dietary consult and asking for it is a really important thing, because the dietary consult will tell you where you're deficient or where you're having too much, and monitoring that. And again, a lot of it is based on the Mediterranean model of food, the MIND diet, which is the DASH diet and the Mediterranean diet combined together. That's what we're doing right now at Rush. But limit the sugar, limit the sugar.
Thank you, Dr. Aggarwal, and thank you so much for your time this evening and for such a wonderful and informative presentation. We appreciate it so much.
Oh, you're very welcome. Listen, and big thanks everyone for coming out tonight. So hopefully you'll be able to take some of these things I told you and practice them. And I guess I want to make one comment. You know, the things I talked about tonight when it comes to cognitive functioning and maintaining brain health, a lot of it is lifestyle, and a lot of it is in some ways common sense, right? But it doesn't mean it's easy. Doesn't mean it's easy to do. And one of the things that people will say, gosh, you know, I just can't do this, or I'm so frustrated. And all I'm going to say is just start off with one thing first. And if I had to choose one thing to start off first with, is movement. I need you to move. I need you to move around. I need you to get up and walk. Walking counts. Walking is a great form of exercise. Walking counts. Walking in the house, walking in the backyard, I don't care. But you need to start with one thing first, and then you build slowly on that. And that's what you need to do. You take it one step at a time, but you build slowly, and you get into a rhythm, and then it gets the routine. And once it gets the routine, then it becomes that lifestyle change, and then you can see changes that affect the whole body. So stay with it. Don't give up on anything, and just be patient. But the brain will respond to this resetting and working at a pace that the brain can respond to, which means you have things in order and things in structure. That's all I'm going to say for tonight. But big thanks everyone for having me.
Thank you.
All right.